So good morning, everybody, and you are all enormously welcome to this, our symposium from Medtronic, looking at the Intrepid device, a solution for transfemoral treatment for mitral regurgitation. My name is Alison Duncan. I'm very, very happy to welcome you all here and delighted to see we've got actually a packed room. There's only a couple of seats left, which is brilliant. It shows and underscores the interest that we've got in this device, particularly given that this is on the last day. So you are all enormously welcome. And to help us through the next hour, I've got a very distinguished panel here with me. We've got Mike Reardon and Tim Byrne from the States. We've got Nicholas van Meegen and Stefan von Bardeleben from Europe. And to my left, we've got Didier Teche, who is also the spokesperson and will be very happy to take your questions via the chat, or please do, in between speakers, please do come to the microphone and do ask us the questions that you want to have us address to you. So just over the next hour, the objectives of the session, I just wanted to state that we are going to try and help you to understand the Intrepid journey so far. So what have we learnt so far, which will help us to understand where we're going? That's been in no small part helped by the early feasibility study, which we will share with you the results of what we've learned so far. For those of you that are chomping at the bit, ready to go and start enrolling patients, we're going to try and help you to understand the screening process so that you know which patients are suitable for this intervention. And then we will finish with hopefully a very active and integrative audience participation. And so with no further ado, I may invite Mike to the stage, please, who's going to take us through the Intrepid journey so far. So you're very welcome, Mike.
So I'm Michael Reardon. I'm a cardiac surgeon from Houston, Texas. I've been involved with the Intrepid program since the very beginning, and take a moment here to go through the Intrepid journey that we've been through. These are my conflicts of interest. So the potential for transcatheter mitral valve replacement is really great. It can be less invasive than surgery. It will enable treatment of more patients with fewer complications and shorter recovery. We think it'll give us a predictable and durable elimination of valve regurgitation across a wide range of anatomies and pathologies agnostic to these. And it's a straightforward procedure for transcatheter operators as we overcome some of the technical challenges. For those of you who haven't seen the valve, the Medtronic Intrepid valve has a conformable outer stent. It anchors without leaflet capture. It's symmetric, so it eliminates the need for rotational alignment. The circular inner stent houses a 27 millimeter tri-leaflet bovine pericardial valve in both sizes. Right now we have a 42 and 48 valve sizes. A 54 valve is in development because one of our loss to enrollment has been big annulus, so something we really need, particularly for our functional patients. Right now we've treated over 500 patients with the Intrepid valve. We have over 200 transfemoral cases, and we have cases out now to 5 years of follow-up. So this is a broad overview of where we've come from and where we are now. We really started with the first generation pilot study back in 2014. We're just learning the valve. We moved to a randomized trial against surgery. And of course, once COAPT came out, that was something impossible to randomize, so we went into a single arm, but we had a recoverable one. We're now, of course, enrolling, and we'll go through that in the future as we go through this talk. We started with the transapical system. It was really easy to put in. It was this straight rod that I put to the apex of your heart, went right into the valve. You could hold it very steady and deploy. The problem is nobody wants a hole in their chest, and nobody wants a hole in their heart. And even as a surgeon, I can tell you it matters if I put a hole in your heart. And some of these functional people, they already have a bad heart, we're going to put a hole in it. But what we did find out from this is that it works. It was easy to put in, and it worked. So we had a pilot study with 95 patients to begin with. These were people with symptomatic, moderate to severe or greater. And then we moved into the Apollo with both roll-ins and cases. So we have well over 200 patients in these. The key follow-ups are the 30 days, 6 months, and annually. As I said, we're out to 5 years with some. Key outcomes, all-cause mortality, heart failure rehospitalization, echo outcomes, New York Heart class, and quality of life through 2 years. We had a central screening committee. This has been fun. Scott Lim and I have run that every Tuesday night. We have the great pleasure of getting on and looking at all these. Echo Core Lab and independent CEC. So the all-cause mortality in the original pilot was pretty high. Why? Because these were really, really sick patients that we were treated. And most of that mortality is in year one. Once you got through year one, it starts to flatten out. We look at Apollo, yeah, it came down some because we selected patients a little bit better. Still very sick patients. That's the average between the two. If we look at heart failure hospitalization, again, pretty high. We start with sick people, and that's how most of these trials start, people that are already well down the pathway. Apollo, really not a lot different than heart failure hospitalization, and the average is right across there. If we look at mitral regurgitation, what we find is this eliminates mitral regurgitation. So one of the advantages of this is that you will automatically, every time, eliminate mitral regurgitation. And people start out in functional class 3 and 4, and the vast majority end up in functional class 1 and 2. This does help people get better. So there's some key findings from the transapical that we learned in 2 years. All-cause mortality was high, heart failure was high because we treated a very high-risk population. There was persistent mitral regurgitation reduction and symptomatic relief in over 80% of the patients now being in functional class 1 or 2. So this is really promising results, but we really need a less invasive procedure. Those of us doing this, we're telling Medtronic, from the word go, we needed a transfemoral transeptal approach. So then we went to the transfemoral approach with the first generation device in 2020. And it's very similar for those of you that do Eclipse. It's a very similar type of arrangement and deployment. It has a very familiar multi-directional steering for access across a range of anatomies, clearly visible in fluoroscopy and echo, and it's a single-stage deployment. The 30-day results were reported by Faraz, and what we found was the outcomes were good. The one thing where we had problem was vascular complications. Most of the surgeons don't really do a lot of venous work. Venous work, for those of us that do open vascular work, is much worse than arterial work, and it fell in every tercile. Now we've gone to percutaneous. Percutaneous is going to reduce this even further and simplify the procedure. Every step makes this easier for the patients and easier for the operators. Closing the ASD that we create, we closed about 3/4 of them. I think as time goes on, we close less of these, and there's more of a thought process. Are they shunning? Is it a big tear? Do they have pulmonary hypertension? Do they have bad TR? It's not an automatic closure. Early on, we were closing most of them because we were learning what we were doing. We were eliminating things that might cause us trouble. But this is becoming less common with time and more indication-driven. There are some lessons we learned about how to image. You really want to image the anatomy and not the device. Your eye tends to be drawn to the device, but it's the anatomy that you're looking at, and you really need to see the native annulus on axis and then bring the device in. You need a horizontal annulus, you need to elongate the LV, and multiplanar imaging really, really helps. If you're going to do this, you have to have a good imager. You don't just draw in your imager of the day. We have dedicated imagers that do every single one of these with us because imaging controls this procedure. So now we've moved on to what we're enrolling now, which is the Apollo single arm in the US and Canada, and the Apollo EU. Tommy Modine, just not too long ago, did the first one in Europe. So we're very excited to have this open and running in Europe. And if we look at the shift, once we've gone to transfemoral, not surprisingly, the number of cases that are getting submitted to us and approved has gone way up. All of us are more enthusiastic to treat transeptal transfemoral cases than transapical cases, and this has really helped accelerate the trial. We've expanded the U.S. to include Canada now and to include a MAC cohort. The MAC cohort is actually one of our fastest enrolling cohorts. We're enrolling now in Europe. There's not a MAC cohort in Europe, but there should be a MAC cohort in Europe because, again, it's the most needed thing. But now we have a very broad international trial. You can correct it. Now, when we look at this, the cases, these are people that we don't think are optimal for TEER. We spent a lot of time defining this. We actually have a TEER group that looks at it. On the screening committee, I try to let the site make most of the decision. Can you get this down to 1+ or less? If you can't, then that's not a good TEER patient for you, and you can start thinking about doing a valve. And then lastly, we'll eventually be going into randomized trials, but we got to get the safety down first, and I think that's where we're going to end up. And that's going to happen when we get to the new device. The new device will be a 29 French device, smaller than what we're doing now, and a 54 valve. So the early transapical intrepid experience demonstrated positive valve performance, but showed elevated rates of mortality and morbidity because of the population. Transfemoral provided us an initial evidence of the transfemoral delivery system, which will be a less invasive route. And the Intrepid transfemoral program now continues to grow. We now have multiple international trials going, and these are ongoing right now. And then I'll pass it on to the next speaker.
Good morning, everybody. I'm Tim Byrne. I'm an interventional and structural cardiologist from Phoenix, Arizona, and I also have been a part of the Apollo journey since its inception. These are my disclosures. So transcatheter mitral valve replacement is an investigational technology for the treatment of MR in high-risk surgical patients. And Michael just showed the transapical data where the mortalities in Apollo were 24 and 27%, depending on which cohort you looked at. And there are lots of access-related and procedural complications and ultimately mortality issues with that approach. The intrepid transfemoral early feasibility study examined a 35 French delivery system and reported no mortalities or strokes and reduction of MR to trace or none in the first 15 patients at 30 days. And I'm going to discuss the FS outcome data at 30 days and 1 year in the full cohort of 33 patients. So here's the delivery system, which Michael already discussed, the intrepid valve design. There were 11 active sites for the study and 9 enrolled patients. It was a prospective, multi-center, non-randomized early feasibility study. Patients are going to be followed through 5 years. The primary endpoint was implant delivery, device-related serious adverse events through 30 days. Key inclusion, we included patients with moderately severe or severe symptomatic mitral regurgitation who were deemed high or extreme risk by their local heart team and had anatomy suitable for TMVR transfemoral delivery. There was oversight by the Independent Physician Screening Committee, the Echo Core Lab at Mayo, and the Clinical Events Committee adjudicated safety events. So here's the patient flow. 234 patients were screened. There were 46 patients that were presented to the screening committee. 11 were disapproved, either because of annular dimension or LVOT risk, and 2 patients were withdrawn. So 33 patients made up the cohort. There were 33 successful implants. 1 was converted to surgery due to valve migration and resultant paravalvular leak. And 1 was attempted but not implanted due to the inability to gain appropriate septal height for safe delivery. At the end of 1 year, 25 visits were completed. There were 3 missed visits and 2 deaths. And both of those deaths occurred beyond the 6-month mark. So the baseline characteristics are just as you would expect: age around 80, nearly 70% of patients with class 3 or 4 heart failure. 60% of the patients had primary disease of the mitral apparatus, and around 40% had secondary disease. The baseline, or the procedural characteristics: the time for delivery of the catheter to removal, only 42 minutes. A preponderance of the larger device, 68% of patients. The 54 is coming. And as Michael mentioned, about 3/4 of the patients had ASD closure, and that really has moved sort of the other way. Probably only 1/4 of the patients have ASD closure at this point. 31 successful implants. 1 was converted to surgery for the valve migration, as mentioned, and the length of stay was around 5 days. And importantly, most patients were discharged not to a care facility, but straight to home, 87%. So looking at the Kaplan-Meier data and the all-cause mortality at 30 days, 0%, and there were no strokes. Out to 1 year, there were 2 deaths, 1 cardiovascular death and 1 non-cardiovascular death following a hip fracture. There was 1 myocardial infarction related to an air embolism very early. That changed sort of the de-airing process of the delivery preparation. And then there was another spontaneous MI related to coronary heart disease later. The major vascular complications we already spoke to. Those events occurred in the first 15 patients, and once we were able to socialize best practices about surgical access and best practices about perioperative and postoperative anticoagulation, those really were mitigated and have improved in the last cohort of patients enrolled. Importantly, there were no heart failure hospitalizations in the first 30 days and only 2 heart failure hospitalizations out to 1 year. And again, a dramatic improvement when compared with the transapical cohort of patients that Michael just presented. So again, the all-cause mortality, no mortalities in the first 6 months, 1 cardiovascular, 1 non-cardiovascular mortality out to 1 year. Again, the echo outcomes, none or mild mitral regurgitation. You see that benefit very early, and it's persistent out to 1 year. Absolutely no paravalvular leaks were appreciated. 1 patient had severe fixed left ventricular outflow tract obstruction 3 days post-procedure, and that was explanted, and the patient was removed from the study. 3 had dynamic left ventricular outflow tract obstruction. All of those were resolved at 12 months. Again, favorable clinical outcomes and favorable hemodynamics with low mean gradients out to 1 year. And improvement in New York Heart Association functional class, all class 1 or 2, most class 1 or 2 out to 1 year, and the benefit is seen again early, with improvement of quality of life. So as an early feasibility study, the study is small, the results, although encouraging, should be assessed in a broader population. Extended follow-up is needed to further assess clinical outcomes and long-term valve hemodynamics. This study correlated and coincided with the COVID-19, which probably impacted enrollment and certainly some of the follow-up. But in summary, the 30-day outcomes demonstrated high device and procedural success, no mortalities or strokes. Most of the vascular complications were mitigated by socializing surgical access technique and anticoagulation regimens. These outcomes observed at 30 days remained through 1 year with a 93.3% survival without any strokes. All patients had MR that was mild or none, and improved New York Heart Association class and quality of life. Larger global studies are underway to further confirm the clinical and hemodynamic benefits demonstrated in the early feasibility study. And this publication, or this presentation at TCT, coincided with 2 publications in JACC intervention, and were led by Farasar. Thank you very much.
Thank you very much, Mike and Tim. Fantastic introduction and start to the discussion. So if anyone has any questions, please come to the microphone. But while you're thinking about it, I just wanted to ask the people who have actually done the implantations, specifically with the transfemoral. It does seem to be fairly smooth. You said procedure time of 42 minutes. What do you think is the learning curve? How many cases do you have to do before the operator feels very competent to do this procedure?
I think it's actually very few, because it's a very straightforward procedure. You do have to realize that it's driven by imaging. And so, again, you just can't have like your cardiologist of the day doing a TEE for you, TOE, I'm sorry. You have to have dedicated imagers. And if you have good imaging, it's not hard to do. Actually, the scariest thing for particularly the interventional side of my heart team was putting this large sheath up a venous thing, and to help to have a vascular surgeon who does this say, we'll get it up, guys, it's okay. And now that we've moved to percutaneous rather than cut down, that actually really simplifies things. I do not like cutting down on veins. So I think it's become a very easy, reproducible thing. I truly think if you do 4 of these, you'll have it down.
So you're starting to already mention the issues about the heart team. So you need the implanter, you need the imager, you need a surgeon, but also just deeper diving into back in history when you were doing the transapical. I noticed at the start of the mortality curve, there was a relatively steep mortality in the very beginning. So presumably this is around the peri-procedural period. You need anesthesiology to help you at the time of the implantation because you're removing MR completely. So this is around potentially managing afterload mismatch, I assume.
Yeah.
And apical bleeding.
Well, the other big difference is all our transapicals went to an ICU and usually stayed at least 2 days because they often had a 1-day honeymoon period. Our transfemorals go to the recovery room in the floor. They look a lot more like a TAVR than a mitral valve surgery.
I have a few more questions, but we've got a gentleman come to the microphone. So congratulations. Thank you very much. Please, what's your question?
Yeah, thank you for these great and encouraging results. I was wondering about the anticoagulation or antiplatelet therapy regimens that were usually used in these patients.
Yeah, so the peri-procedural anticoagulation begins the night of the procedure with warfarin. We're doing DVT prophylaxis doses of heparin or Lovenox. Initially, part of those 8 patients that had all the vascular complications early, some of the sites were doing full dose Lovenox on the night of the procedure, and that's all been changed. So it's 6 months of warfarin as tolerated, but it's also the site's choice. And there are some sites that are using DOACs, and specifically Eliquis.
Yeah, we've known for decades that the mitral, from surgical valve replacement with bioprosthetic valves, it's a much more hostile environment for clotting and valve degeneration. And I've always anticoagulated my mitral biologic valves for usually 3 months. It's a different environment. So we anticoagulate these for 6 months. I don't think we know what the right answer is. We're learning that answer as we go forward. But you do have to anticoagulate for some period of time. The question is how much and how long.
And to go along the theme of audience participation, Didier, I think there's a question on the chat.
Yeah. There is a question from Giuseppe Martucci, who is online. So please feel free to use the microphone and to come up with any kind of comments. It's once again a question for you guys. It's moving from the transapical to transfemoral approach. There was a significant drop in the mortality rate. Could you elaborate a little bit more into the reasons for that? We heard about the bleeding, but were there any intrinsic reasons for such a drop?
Well, I just think that, we knew from TAVR that the transapical or the direct aortic approach, when you compare it to a transfemoral, a safe procedure like MitraClip or transcatheter edge to edge, it just changes the entire dynamic. So putting a hole in your chest and a hole in the apex of your heart, it hurts people. At the end of the day, that's really the bottom line.
Yeah. Early on, we had these discussions when we were going to randomize against surgery and use transapical. And I tried to tell some of my surgeons that transapical was bad. And they said, oh, no, it's a small incision, a little hole in the heart. Well, if it's your heart, it's not a little hole.
Didier?
Yeah, so it's more about, I would like to have a general discussion with you guys because you are a visionary, you have a vision about the future. And last year or 2 years ago, we had a poll for a TMVR session, and it was all about understanding from the audience what was the future going to look like. And the vast majority of the people said it's going to be TMVR as the default strategy. We're seeing that it's more TEER. We have very reassuring data about TEER. It's going to succeed in the future in terms of preventing LVOT obstruction. I have no doubt about that. But how are we going to position both elements? Is it going to be only about patient selection, not suitable for TEER, or is it going to be about anticipating the future of the patient, the need for reintervention? That's what I'm struggling with.
I will let Stefan, but my first point to that is, first of all, of course, this is not just for patients who are not suitable for edge-to-edge, and the population, the community is getting extremely good at taking on patients that were conventionally or historically not felt to be suitable for edge-to-edge. But I think a subset that we will really target will be the MAC patients, but also we need to have future developments in the profile of the devices and with managing almost routinely anterior leaflet pathologies. Stefano, did you need to add something?
Yeah, I totally agree. I think TEER has been much more successful than anticipated 5 to 10 years ago. So we have more than 230,000 patients treated. And I think the red zone is moving a little bit to the right side. But there are patients that are untreatable. And those are rheumatic heart disease, any sort of mild or moderate stenosis combined with severe or even moderate to severe and severe regurgitation. This is untreatable but TEER. So we need other solutions. And we learn from the tricuspid space, actually, that the 30-day mortality is approaching to TEER. This is our learning curve there. And we are also using 30 French sheaves in the tricuspid space. We're getting to 0.5 to 3% mortality. So the EFS study goes in the same direction. We see 0%, even if it's a small cohort, but you can expand this. So we're seeing this is a safe opportunity, and it's always a benefit to risk ratio. So if we get the procedure very safe, we also automatically have more benefit to the patient, because the patient wants to survive. He wants to have an efficacious elimination of MR, and only then he can take a benefit of it.
Nicholas, do you have any extra gems to add?
Well, my general comment would be that the challenge will be to identify the sweet spot for TMVR. We all are familiar with the difference between primary and secondary MR. I think secondary MR we should not treat secondary MR as primary MR. And there are patients with secondary MR with poor LVs where maybe the goal is not to abolish MR. Maybe the stakes are not that high in terms of MR reduction in order to improve the patients. And I think this is an important message that we got from COAPT. Patients had residual MR and still had reasonably good outcome. Granted, at 2 years and at 5 years, the mortality was high. But I think the sweet spot probably is not in the patients with very poor ventricles. It's more, in my opinion, in degenerative MR and in patients where the surgeons will not do a good job with their repair techniques.
And finally, just before we move on, a quick pragmatic question to our brilliant American colleagues. How do you decide whether to close the ASD or not? What are the factors that go through your mind at the end of the procedure to decide whether or not you need to close the ASD?
Well, I think Michael spoke to a lot of it, but if you see bidirectional shunting, right to left shunting, significant pulmonary hypertension preoperatively, or lots and lots of TR, those patients will likely be closed. But I would say I haven't closed a septal defect in probably a year. So most of the time now, leaving the atrial septum open is important for so much of what we do. So I think that's the move. It's a move away from closure, and very few are being closed at this point.
So, Tim, if you're going to close, does the device matter? Does the device you use matter?
Exactly.
It might. I'm sort of an Omplotzer guy, but I think you can use any device.
Okay.
So I think it's a very important point, Mike, that you raised. The type of device could be a difference, because there have been cases, and I've done a couple of cases like that, of transeptal puncture through an ASD device. And you can it's achievable, but we need an improvement in the overall profile of the TMVR devices to do so. There are a couple of questions from the audience. So the first one, if I take them into order, comes from Julia Stelly, who is on site. We're going to elaborate a little bit more upon the mechanisms, the fixation mechanism of the device. But there have been patients for whom withdrawal of the device was needed for LVOT obstruction. Did you, as surgeons, see specific anatomical considerations in terms of damage to the LVOT, damage to the leaflets, things like that?
Well, if the question is, do we see specific things about who we shouldn't put it in because they're going to have LVOT, we could talk in the next couple hours about that, particularly as we get down to the edges of who might or might not. There's some that are clear that they're just not going to work, and there's some that are clear they're going to work. In the middle is where we have our trouble, and we're kind of edging. If you take these out, you're really not going to see any damage to the septum. I mean, it's just the problem is push the anterior leaflet up, and it's just blocked off the septum. And so once you take it out, and when we operate on you, we take your anterior leaflet out, or at least most of it, and then move the cords down. I move down to 4 and 8 o'clock and pull them out of the LVOT, and then we put a valve in there, and it's okay. That's why, a TAVR and a mitral bioprosthesis works, because there's no anterior leaflet. It's been removed by the surgeon. But you're not going to have any damage when you take it out. The problem, of course, is you have to operate on these people, and we're doing this to try to avoid an operation.
But Didier, what is interesting is that there were several cases with dynamic LVOT obstruction and LVOT obstruction that like faded away over time. And I think an important difference between a TMVR procedure and a TEER procedure, for instance, is in a TEER procedure, you would like to have the patients as dry as possible to improve coaptation, to ease the grasping. With a TMVR, you don't want to do that, because if the patient is relatively underfilled, you will increase the risk for LVOT obstruction. And then obviously your first treatment will be filling of the patient, so fluid therapies. So I think this is a very important concept that we also need to take into consideration, and that probably we were not appreciating in the early days of TMVR.
And I think it's the same situation directly during and after the implant. And this may also be a cause that transfemoral transeptal is safer, because you tolerate easier a higher volume load in these procedures than you do transapically when you close the ventricle, when you may have lower pressures, when you may have more inotropes, etc. So inotropes are bad in these procedures. Volume is not bad in these procedures, and you typically massively reduce, if your anesthesiologist plays with you, that you minimize these risks of dynamic LVOT obstruction.
And there is a risk of bleeding with transapical.
Sure.
And that does knock your volume down rapidly.
Yeah.
So, gentlemen, we're going to move on for time, but now you are in for a treat because we've got the holy trinity of the European contingent here. They're going to blast you through some case examples to help you to understand the sorts of patients that will screen pass, screen fail, and how well they'll do. So I think, Didier, you're up first.
I think, yeah, the first case is for me. So this is the patient that we're gonna discuss. So it's a 17 years old female with a severe mitral regurgitation, as you can appreciate. In terms of comorbidities and risk factors, you can see that the overall DSTS score was 2.7%, but the LVEF was 36%, so a depressed LVEF. So we discussed about the transapical versus transfemoral, and this could play a role in the access site choice. Pulmonary arterial pressure was quite high, close to 60 millimeters of mercury, and a bit of mitral nullinar calcification. But what is really striking when we have a close look at the echo views with this, it's not, kind of MPR reconstruction. What we can see, apart from the severity of the mitral regurgitation, is the complexity of the disease. And this is a rheumatic disease with extreme tapering of the leaflets, thickened leaflets, multiple jets from the commissures, the lateral commissure, the posterior commissure, so diffuse jets. And so that's something that we may discuss. But do we agree that this is not a good candidate for TEER? Would you, given your experience, Stefan, would you go for a TEER in that situation?
I think we see the disease in tethered leaflets, especially the posterior leaflets. If you look at the lower left, I totally agree that here a replacement is the way to go.
So that's a good illustration of the type of patient in the future for whom this therapy would be indicated. So there is, you're going to see that through all the cases that we're going to discuss. CT assessment is part of the equation, and we had a session this morning on TTVR, and the agreement was that for any kind of structural heart disease intervention, now apart from the echo assessment, CT is almost mandatory because it's part of deciding upon the best strategy for your patient. So here the perimeter-derived diameter of the mitral annulus was close to be 39 something, indicating the suitability for a 48 millimeter device. So this is we talked about that, the transeptal access. So we are all familiar with the TEER procedures, so we are aiming quite high posterior, and here the transeptal puncture was at 4 centimeters, which is good because you need room enough to be able to articulate the device and to steer towards the mitral valve. For those who are familiar with these large bore devices, increasing the path through the septum makes sense, and there was the first step. The second step is a septostomy with a balloon, 14 by 40 millimeter balloon, just to make sure that you're going to put the guide shift nicely across the septum. Then it comes about measuring, making sure that you have, as we do for a mitral TEER, whether it be Pascal or the mitral clip, we make sure that we have enough distance from the septum access to the mitral annulus. And here you can see another important thing on the left part of the slide is making sure before moving a little bit more forwards, making sure that you have enough delivery system within the left atrium, and you need more than 4.5 centimeters to make sure that you can safely withdraw the guide and now steer appropriately, expand everything, and steer towards the mitral valve. So that's one of the requirements. So that's the type of imaging that we are getting more and more familiar. Like a couple of years ago, it was a little bit confusing for us, but now we are really familiar with these MPR reconstructions and seeing every aspect of the mitral anatomy. So you can see that the valve is navigated across towards the mitral annulus, and it's the same, achieving proper perpendicularity, whether it be in the anterior-posterior direction or the septolateral dimension, being as central as possible before exposing the brim. You see the brim that is expanding. The brim is the atrial portion of the device that is going to seal the mitral annulus from the atrial side. So it's very important to make sure that it's nicely located within the left atrium, in contact with the mitral annulus. You see that there is still a bit of the movement, despite the fact that the LVLT was 36, the LVF was 36. There is still some dynamic contraction of the mitral of the left ventricle. So for this purpose, there is a rapid pacing that is achieved. It can be a quite long rapid pacing, but we are used to that when we're doing any kind of mitral, whether it be a TMVI with a balloon expandable platform in MAC or a ring or anything like that. We are used to that longer pacing, and it's very much well tolerated by the patient. So rapid pacing, expansion of the ventricular portion with the cleats securing the anchoring. And you can see this is the final aspect. And clearly, we have to admit that with this type of devices, getting zero regurgitation is going to be the gold standard. It's going to be the routine aspect. So mean gradient of 2, no leak, no paravalvular or transvalvular leak, and no need for any ASD closure. So that's I think I'm going to hand over to Stefan.
Stefan, I think
next case.
Well, he's loading up one comment for those that haven't used this valve. You see those flanges come out, and your first thought is, well, okay, I'm going to use those to butt up against the atrium. They're nothing but markers. They don't have any strength to them. First time I thought is, okay, I'll just shove those things so they hit the atrium and that'll stop them. But they're only markers. So for those that haven't done it, all we're doing is locating with those. They don't really do anything but show you where you are.
Yeah, it's my great pleasure to continue with the first case in the Apollo EU trial. And just to give you an update, there are 6 countries where the protocol is now approved in Europe. So we're moving fast forward. And there may also be a MEC cohort next year in the European part of the Apollo EU trial. These are my disclosures. If we talk about the eligibility for patients between TEER and non-TEER suitability, we have a pretty good draft by Scott Lim here in this red paper, putting out a straightforward TEER anatomy that goes to IFU uses, more complex TEER anatomy that can well be treated by more experienced centers. And of course, our total human experience with TEER is relatively high. We have a low screen fail rate, but there is a red zone that may be individually described per center, and this is the sweet spot where we move into with TMVR devices. TMVR devices on themselves have moved massively away from functional secondary MR with large ventricles where they were originally designed, and they move now, as you've seen the EFS trial, to 60% primary with some sort of leaflet change. This may be radiation, this may be calcium, this may be restriction, as nicely shown in the case by Didier Cheche. So I think we're learning more and more, and we may not only have to use larger valves, but also smaller valves as we move into some MAC cohorts. And now 25 to 30% of the patients actually are MAC patients that are newly entering the field. You've already seen this nicely by Michael and Tim. It's a conformable outer stand in the intrepid valve. It's an inner stand that carries the valve with about 27 millimeter valve design. We have a 35 French intrepid transfemoral system where we're starting in Europe, but also we've seen The journey is going on, so we're anticipating in the first half of next year to actually moving down to a 29 French system that will also be transfemoral. Just to give you another example here, this is a 78-year-old male that was treated in France. A moderately to severe MR, you see the etiology is type 3B. Again, we have some restriction you can see on the upper right image, and I like to take the comments of Ellison too. You can see next to the circumflex artery, we have changes to the posterior leaflet near the ring. There is calcification. There is partial immobility, so the movable part of the posterior leaflet is impaired. You can nicely see that there is a central indentation if you look at the 3D image at the lower right, where we have a central indentation in the segment 2, where we have some calcification nicely visible here more on the medial side. So this is not something you can easily grasp on both sides. You would immobilize the valve, you would gain gradients. And we see this patient is diseased. We have an impaired ejection fraction of 36%. We have an elevated PA systolic pressure here of almost 100 millimeters mercury. So definitely not a patient that would well go into surgery and to have open heart surgery. But still, even with this comorbidity, we have no atrial fibrillation. We have only a mildly reduced RV function, which is also very beneficial for the case itself. So again, like with the first case that you've seen, again, we have an analysis, and we're moving more and more to CT analysis of these cases, of course, and TMVR enforces you to use CT cases, but we will learn more about dynamic models to really evaluate LVOT obstruction, which is one of the two main reasons for screen fails in these populations. You see this ring is smaller, 3 millimeters smaller than the case that Didier presented. The parameter is below 120 millimeters. Thus, a valve size of 42, so the smaller valve had been chosen. You can see typically the transeptal puncture, and this is a nice image because you see the fold, the muscular part where you enter to the pericardium, so you have to stay anterior to it. That's very important, but we want to gain height, and this doesn't mean you have to be most cranial, but you have to be away from the valve, and you can nicely see this in fluoro. Again, the septum is dilated as we do in any valve and ring situation with a 14 by 40 millimeter balloon, so this is also a standard therapy. Pre-curved sheath is put into the left atrium, and then we go into the device situation that you've seen before. We use a pacemaker in order to get a rapid pacing that typically will be around 20 seconds to 35 seconds, just to give you an impression. A little longer than nowadays with the TAVR procedures, but not excessively long. You introduce the system without a wire into the left atrium across the sheath, and then you navigate down by respecting the lateral anatomy, as you can see on the right-hand side, with three-dimensional echo plus fluoroscopy guidance to get down. And here we see the perpendicularity. So in the most left image, you can see the flexing option, which is an intercommissural view. You can nicely see the coronary sinus on the left as a dark black hole. On the right-hand side is the LAA. And this gives you a perspective on how much you want to flex the system. The second picture to the left gives you the hugging situation. So if you come flat with a very anterior puncture, you would come flat down from the aortic valve. If you want to come steeper, you have to be more posterior, and you also can flex the system to adapt to this. And on the right-hand side, you can nicely see the expansion of the atrial brim, and you get a good impression that we're totally perpendicular, both in intercommissural and in the three-chamber view, to the native anatomy and the hinge point of the annulus. And this is again done under three-dimensional biplane, or nowadays also MPR echocardiography plus fluoroscopy surveillance, which is standard fluoroscopy, so you don't need anything else. Here you can see the situation when we move over to rapid pacing. You can see there is some stasis in the atrium for a short moment. You then deploy the valve, and you can see the restoration of flow and function in step number 3, where the valve is completely opened. Also in the ventricular part, which is the second step, you then close the capsule and remove the capsule from the ventricle back to the atrium, and the procedure basically is finished as we know how to handle these ASD sizes. So you see the valve landed in the first cleats. It's very nicely seated. As you can see, the LA still is open, can be closed by an interventional device too if needed. You can see a very nice valve function, and we have no paravalvular leak. And also in this case, as in the last cases, the majority ASDs are not being closed if there is no persistent right to left shunt. The mean gradient is 1, the peak gradient 3. You see trace leak situation or non-leak situation, and also a very, very good valve function that we can appreciate in 3D. Thank you very much for your kind attention.
Could you just come back? I find it very interesting, on the 3D image, the way the inner stent disconnects from the brim. Yeah. The brim takes the D shape and the inner stent remains circular. So that's really something, a feature that dual stent architecture, I think is going to make sense in the future for...
Absolutely. So the inner stent having more force is needed for durability.
Yeah.
So the more round the inner stent remains, the longer maybe the lifetime management durability known from surgery, while the outer stent is there to seal, to conform, so it's softer and it conforms to the anatomy. It may become elliptic as the natural mitral valve annulus. It's 3 by 4 in relation, so it's never round. So this is why in mitral, dual stent designs are very important. I totally agree.
I've just written down a rapid-fire load of questions here, but just to make sure we fit in Nicholas's case. Nicholas, do you want to present your case first, and then we'll see how much time we've got left at the end?
All right. The third case is a case from the US. These are my conflicts. And it deals with an 84-year-old male with severe MR, secondary MR type 1 is it classified, and you can see the echo images. Patient is highly symptomatic, New York Heart Class 3, has a high STS, predicted risk of mortality of more than 8%. He also is deemed frail, and then his ejection fraction was 55%, moderate TR, moderate pulmonary hypertension. He has some kidney issues. There is no previous mitral valve surgery, no prior implants, no pacemakers or ICDs involved. I think what is interesting here is the reason for TEER ineligibility. It was deemed that the multiple jets would be a reason to believe that TEER would not be the best option for this patient. Also, the posterior mitral leaflet is relatively small. It's less than 10 millimeters. I must say, in my practice, if there is no other option, I would attempt a TEER procedure. Obviously, we all know that if you don't manage to have a good grasp, you can always retrieve the clip. That would be a current reality. Obviously, if you have an alternative, a functional, effective, and safe alternative, I would agree that this would be an ideal patient for mitral valve replacement. The importance of CT has been already emphasized. In terms of sizing, this is in between the sizes of the previous two cases, and again, a 48 millimeter valve was selected. I think the majority of the cases are the larger valves, and that is exactly why there is also a third valve size coming up in the making. At the same time, in the data from Michael and Tim, it was also obvious that I think 2/3 of the patients received the larger valve, the 48 rather than a 42 valve. Again, the septal puncture. I don't feel the septal puncture overly difficult with this device. This is very much the same as we do with a mitral clip or a Pascal. It's 4 centimeters or a little bit higher. We're quite familiar with that. We also typically want to go for a more posterior and an inferior puncture. So nothing exotic there. So the goal is to aim for 4 and preferably not to exceed 5 centimeters. This is then images from the procedure itself. So after the transeptal puncture, you deliver the sheath over a stiff wire, and then the wire goes out. So you insert the delivery catheter not over the wire. So that is also an important distinction with other technologies. And here you see that some modifications of the positioning. On the left-hand side, you see in the 3D image that the device is relatively close to the commissures. And then if you want to get away from the commissure, where we are now too medial, and you want to go more to the center, you do a typical maneuver that we're also familiar with from our TEER procedures. You just push on the cradle, and the cradle is the system outside of the patient that holds the delivery catheter. And it's a very simple maneuver. Again, nothing exotic there. And then you see on the right-hand side that the system has become more centralized, a little bit to the medial, an ideal position to open up the brim. And this is shown in these fluoroscopic images. The brim was then expanded. You expand the brim at about 2 centimeters above the annulus. And then the final deployment is being done either under rapid or very fast pacing. In this case, it was at 180 beats per minute, with again a very stable positioning. So there are no surprises with the deployment under fast or rapid pacing. The post-deployment results are demonstrated in this slide. The first row of cleats seem to be in all 4 quadrants, and that is what you want to achieve. Well, I must admit, I did not know what the word cleat was in English. I don't know whether you know it, but it's just, it relates to the hooks that are being used also for stabilizing and for anchoring the device. The mean gradients were low. There was no leakage, no relevant leakage. And also in this case, the operators decided not to close the ASD because there was no right to left shunting. That's it.
Brilliant.
Thank you.
Thank you, Nicholas. That was brilliant. Now, we've only got 7 minutes, and we're just going to go some quick rapid-fire questions quickly. Upper age limit. You are both young patients, but you had an 82-year-old, so no issues with age for entry to the trial. What about the patient with pulmonary hypertension? Your patient had pulmonary hypertension, Didier. Do we take patients with severe pulmonary hypertension?
2/3 of systolic is the cutoff.
Perfect. The next question was the length of the rapid pacing. There was some clot in that left atrium, smoke appearing, so presumably the patient was hypotensive. How do you convince the anesthesiologist not to start giving adrenaline? Do you just tell them to wait, just wait?
Just wait. And again, hopefully you're working with somebody that's done enough of this that you always see smoke. It's what you expect to see because you no longer have regurg. The blood's stagnant there for a minute. And you know, it's okay. I mean, we think it's a lot of pacing. If I bring my EP guys down, they sneer at this amount of pacing. It's like.
I always ask the anesthesiologist to step away 5 meters from the table.
I had to come back afterwards.
And then closing, how would you close? All closed surgically?
Surgical?
Early on we cut down on all these, and so we closed them with little pledgeted proline sutures, but now we do it percutaneous. I put one ProGlide in there. I put a figure of 8 in the skin. When I pull it out, I close the ProGlide, I pull a figure of 8, I hold it. They do fine. I mean, going to percutaneous is a huge advance.
Do you give protamine?
Huh?
Do you give protamine at the end of the procedure?
I always do, but my cardiologists don't want to. So surgeons like protamine, my cardiologists don't. I use it every day.
And when do you start your anticoagulation? Is it the next day?
No, I like to wait 6 hours, and after 6 hours, I'm okay.
This is how you pack a load of questions into 30 seconds.
And there are lots of questions coming from the audience, but I'm going to try to merge them into main themes. So the first question is from Yingxiang Li, who is on site, about the suitability of the device for mitral stenosis for Mike.
For mitral stenosis?
Yeah.
Well, the problem is that we have some MAC with a little bit of stenosis, but it's not intended for mitral stenosis. We would all like a device for mitral stenosis, but this is not. You have to have at least moderate in your MAC arm to get in. So if you have moderate MR and some stenosis, we can do it, and then we argue about should we balloon or not, which is just something we don't know. We're learning as we go.
So the reason not to use this for mitral stenosis is because we don't know that the radial force will be sufficient to overcome the mitral stenosis.
No, because it's not a trial of mitral stenosis. It's a trial for mitral regurgitation. Maybe the next trial will be mitral stenosis, but you can do stenosis as long as you have at least moderate. Now, if you have at least moderate, you can't have that bad of stenosis.
Didier?
Okay, so maybe for you, there is a bunch of questions from Giuseppe, Andreas Rock on site. So about LVOT obstruction. First, the screening failure rate due to that reason. And second, if you could provide a guidance in terms of what is acceptable in terms of neo-LVOT.
Yeah, so there's an algorithm that Michael deals with every week as far as LVOT obstruction. And I don't know the exact numbers, but more patients are excluded related to LVOT than annular dimension, but it's sort of close. LVOT obstruction is the Achilles heel of this device. It'll be aided by the 29 French, which will allow us to include more patients, as will the 54 millimeter device. That may not help LVOT obstruction risk, but it will allow us to screen in more patients. How do we manage LVOT obstruction? Right now, we're a part of an artificial intelligence algorithm that is trying to allow more patients in, because as we do the LVOT measurement today, it's with the valve fully expanded, not compressed. And there is a percent of oversizing that we do for each of these cases, number one. Number two, moving forward, are there going to be leaflet modification procedures? Are we going to send patients for the Sesame procedure? Is there going to be a site? Do we send people to Atlanta for the Sesame procedure? So looking at this all moving forward is going to be an important move as we enroll more patients. And then device iteration number next is going to, is there an open cell design at the LVOT that will help us enroll more patients? And you want to speak to the algorithm for the LVOT?
1.5 neo LVOT you're in, 1.2 or less you're out. Between 1.2 and 1.5 I do a multi-phase. Then I look at your angle, and we make a considered decision based on what it was like at 10%, 20%, 30%. 2/3 of your ejection is gone by the time you get out of 20%.
So very short comments maybe from your side, just to be sure that we address all the questions from the audience. The first one is about anticoagulation. You browsed that answer before, but how long? How long would you anticoagulate your patient after the procedure?
6 months.
6 months.
In 6 months. But again, that's a guess. None of us know what the right answer is. And so longer than I do surgery, which is 3 months, but less long than lifelong.
Okay. And maybe for you, from skin to skin, the average procedural time, roughly?
The last two cases we did were 22 and 28 minutes.
So very, very short.
Okay. So just to wrap up, everybody, thank you so much. Thank you for coming. Thank you to a very esteemed team. We're all excited to engage with this process. It looks like a very interesting valve for us to use. If I could just have my last slide on the screen, just to say to you that we have spent the last hour reviewing the Intrepid journey. We've presented data from the EFS study, and we've had some fantastic presentations from our colleagues, how to screen patients and how to perform a successful procedure. So we're really grateful for a full audience, and we hope you understand our enthusiasm for this device, and I wish you a good rest of the day. Thank you very much.
Thank you. Good job.